lot of new studies that show that women don't present with heart attack pain the same way men do. So men come in, they have left side gripping chest pain that radiates to their left arm. Women may have it radiate to their ear, and it's not the same. And then the women therefore die of a heart attack, and the men gets taken straight to a cardiologist.
You're listening to Data Nerds in the OR, a surgeon's journey toward value-based care. The podcast focused on data and data science as the keys to a better healthcare system. Ideas brought to life by the vision and experience of host Dr. Bruce Ramshaw. Each week, Dr. Ramshaw sits down with different players in the healthcare system to discuss how data is used today and what it could do if it were used effectively, how it could improve surgical quality, education, outcomes, and drive better patient care. Let's dive into the latest episode. Here's your host, Dr. Bruce Ramshaw.
So thank you. It's a pleasure today to be talking with a good friend of mine, Dr. Shirin Towfigh. Shirin comes with a ton of experience doing podcasts herself, and she is a hernia nerd like me. We worked together in the Hernia Society for quite a while. We have a lot of similar passions, but she's very well regarded. She's very well published, and I'd like to let her introduce herself a little bit more. Tell us about you. And then after you introduce yourself, I want to hear about your thoughts on the state of healthcare data in our healthcare system today.
Thanks so much, Bruce. Yeah, we're good friends, and we met in the hernia world. Bruce, of course, is one of the major leaders in the hernia world, and a lot of what I've learned has come from what Bruce has done clinically, but we do share the same philosophy. We're very patient-centric in the way that we evaluate patients, and we are not shy to take on puzzles and difficult clinical scenarios. And so we've shared a lot of patients that way. I really love that we continue to collaborate. So thanks very much, Bruce. I'm happy to be here.
Yeah, thank you. Maybe tell us a little bit. And you have a wonderful private practice. You really, not only are you an excellent surgeon, you're an excellent businesswoman. I know I've spent some time with you in Beverly Hills, and I know you have a wonderful team. But maybe talk about not how well your practice does, but the overall state of healthcare and healthcare data. What's your view on the current state of healthcare data in our healthcare system?
Yeah, that's a very interesting topic because data comes from all different avenues. I have my own personal database, right? So that is data that I control. I know details from every single patient. So it's very granular in the data that I can provide. I also submit my data into a national quality collaborative where the data is pretty much anonymized once it gets to the database, and it gives you an opportunity to learn about what happens on a national basis. I think there's maybe 400 or 500, 800 in that range, under 1,000 surgeons that are involved in this national hernia database. That's a different database, right? So there's specific data points that are captured and specific data points that are definitely not captured. So it has pluses and minuses. You can make generalizations about clinical data, but you can't really hone in on a specific problem with accuracy. The hospital had its own database, right? So a friend of mine recently, who's a surgeon, has moved into the administrative world and is a chief medical officer at a major hospital, and the data she's seeing is totally different than the data that clinicians see. They look at outcomes. They've got a lot of kind of population data from the hospital, from infections and readmission and use of resources. Most of it is never shared with the physician, but now she's seeing it, having had that experience as a physician. So just came back from the European Hernia Society meeting. Sweden, Germany, Denmark, they have very robust national databases. They're able to provide 15-year data on recurrences of hernias, for example. Again, similar to our own national database, it's limited as to the data that they can find, but because people in Sweden tend not to leave Sweden, people in Denmark tend to live there forever. Once you're born, you're in this database until forever. So the type of data that we can get from some of these larger national population databases is very, very unique. and great. I'm glad someone like you, Bruce, is involved because you understand all that. And I think what we'll be discussing more is how important it is to know where the data comes from and understand the population database is different than an individual patient and what happens to them.
Yeah, I think you mentioned it. We do a lot of work in various ways, like you suggested, either at the hospital level or in registry level or at national level. And it tends to be only centralizing the data, putting aggregated data together, and certainly that can give you trends and high level and averages. But I think what we've not done well is use data in each local environment across the whole patient cycle of care. There's lots of gaps. I'm sure the data that you're collecting in your practice is much better than what most clinicians have, because you have the resources and the ability, and like you said, the control to do that. And that's, as you know, that's what I did for years with teams of data scientists to learn how to do data science really well. And I think we need to teach that more and more because, like you said, it's kind of fragmented. The hospital has this, the centralized registries have that, and the clinicians, we don't have the data that we need typically to really understand. We're doing our best with what we have available, but one of the big gaps, as you know, is follow-up data. We don't have any, follow-up data, and the other is lack of understanding of the differences in different local environments. That's aggregated centralized data gives you averages, but when you look at each local environment, that's, they're all unique, right? So you told me about an experience you had working on a project with, I think it was Southwest Surgical Congress, about bundles. And this was probably much earlier in my learning about system science and data science. But when you described that project and the surprising results, it definitely clicked that, oh my gosh, that is data science. You can't do the same thing in every local environment and have the same results. Maybe can you share that experience?
Yeah. So when I was employed at Cedars-Sinai Hospital, we were among, I think, 9 other hospitals in the nation that were chosen by the Joint Commission, Center for Transforming Healthcare, to come up with a evidence-based bundle of things to do to reduce surgical site infections in colorectal surgery. And we won the award for best project, which was kind of cool. But I worked with these data systems experts and people that were black belts and all these different things that I didn't even learn about before. But we came up with a bundle, and it involved everything from preoperative preparation of the patient, cleaning them and washing them with certain chlorhexidine type preps, and then antibiotic dosing, and then changing instruments for closure after you touch the bowel, which is considered contaminated, and then changing your gowns and gloves often, and having a whole new set of instruments to close the skin after you use the similar instruments for cutting the intestine, for example, and so on. So we show that you can dramatically reduce. I think we went from like 25% approximately infection rate down to, I think, 7%. It was a dramatic reduction. But even within our group of surgeons, we had one surgeon that had a 0% surgical site infection rate before we started the bundle. So we said, okay, we're not going to change you.
Right.
We're going to make you better.
Right.
So let's learn from you what you do. He used a lot of betadine, and he was just a very good surgeon. Probably his surgical technique was one of the reasons why there was very little tissue injury and therefore infection. And then everyone else, we mandated this bundle. And then we present our bundle, and the other 9 hospitals, it included things like Cleveland Clinic and, Cleveland Clinic, I think, NYU, a bunch of very just large hospital groups that had colorectal surgeons very actively involved. And everyone had their own kind of bundle, and some people showed that using their bundle didn't make a difference. We showed a dramatic difference. And then right after we did ours, there was a publication that followed a very similar protocol, and the publication was, it makes no difference. Even if you do all that, there's no decrease in surgical site infections. So you kind of throw up your hands as to like what works where and how much surgical technique has to do, and individual surgeon influence has to do with implementing these bundles. And it's a little frustrating, right? Because there's no answer. And I think as surgeons and doctors in general, we understand nothing is black and white.
Yeah.
But, patients don't understand that often. They're like, well, why can't you just reduce the rate? There must be a couple things you can do to reduce the infection rate. Why did I get an infection, for example? Or why did I have a hernia recurrence, for example? We can say, well, you have an X% risk of getting infection. They'll say, well, you told me I only had, I'm going to make this up, a 5% risk of infection. Why did I get an infection? Well, you're in that 5%.
Right. Sure.
To them, it's like almost zero risk, but to a scientist, it's like a real risk. It's just, not a very highly expected risk. So it's frustrating that we don't have perfect systems.
Right.
That's kind of why you belong.
It would
Sure.
be simple if we were just a static mechanical system and we could just figure out what's the right one answer for every static mechanical system that's the same, but we're not. We're complex biologic organisms, constantly changing. And that, when you shared that experience, it was one of the aha moments for me that kept me understanding that we are complex systems, constantly changing, and that we can't do one size fits all. And the data science is really the key. Once we have a data and analytics infrastructure, we'll be able to generate algorithms and identify different clusters of patients. Because if you do the same thing for every patient, you're gonna have different results. But if you can identify the cluster of patients that could get A, B, C to drive lower infection, and then this other cluster gets X, Y, Z to drive lower infection, now you're matching the right patient cluster with the right best value treatment. Yeah. And, other industries have started to do that, like Netflix and other industries. They look for different patient clusters. The consumer food industry has done this. That's why we have different types of spaghetti sauce, chunky, spicy,
Yeah.
It's to match with the right cluster. So yeah, that was a good, it was a good story for me to understand that experience you had.
Well, I always share your story, which is when you had your lab and you were testing mesh samples when mesh was being removed, the same exact mesh, sometimes by the same surgeon,
Yep.
implanted in two different patients, had a different outcome. And, how do you explain that? So,
Yeah. Well, that was what started blowing my mind.
yeah.
When we did that, that was just so different than what I was expecting. Because, like a lot of us back then, we were teaching it was all about technique. If you put the mesh in with good technique, you're going to have a good outcome. Now that's not always true, because there are other factors that we didn't know about. So that was very helpful. Another topic, there's 3 or 4 topics I want to cover, and they all are somewhat related to data, but there are also things that we're both passionate about. And you've done a lot of research in these areas. One is the concept of gender discrimination, gender bias. I know in healthcare, like many other industries, over decades, we've seen significant discrimination, and specifically in hernia disease, we have some biases that I know you have studied very thoroughly. So I wonder if you could talk about and both, either or, some of the discrimination you've seen, gender discrimination in healthcare, and then also specific to gender bias around data and hernia and things that you've researched.
That is something that I've grown to absolutely love about what I do. Back in the day, it's now been 22 years that I'm in practice. So my first hernia society meeting was back in 2002. And, I was one of, I think, 2 females in the entire audience. And the first female to be invited to be an editor for the journal, which is great. They specifically asked me to come on because they've never had a female, but it just kind of shows how you can kind of be in a club and then not really understand that the club is very exclusive. So I think because I was female, there weren't as many females back then who overtly kind of did hernia surgery. I started getting more women to see me and referred to me, and then I would talk with gynecologists, and they, there are a lot of women that are gynecologists, and all their patients are female. So I started the point where I pretty much have almost 50-50 male to female ratio in my patients that I see, which, as you know, it should be about a 7 to 10x difference between males and females. So you should have 7 to 10 times more males and females in your practice. the fact that mine's about 50-50 implies I'm getting a very disproportionate number of women. It may also imply that more women actually have hernias than it is currently appreciated, right? So I started seeing a pattern, right? They started talking about symptoms that men weren't telling me about, like pain with sexual function. They were having like a lot of like frequency in urination or worse pain during their periods and so on. And those were all things that we never learn as symptoms associated with hernias in males. And so I started hearing the same symptoms over and over again, and pretty soon learned that males and females not only have a different like predisposition to hernias, and we know their anatomy is different, right? The anatomy of the pelvis is very different than males. The shape is different. The size is different. The nervous system, like nerves that are in the pelvis, is much more in women. But also the way what they complain about is different. So if you're not taught in medical school that A, hernias hurt, and B, you don't have to have a huge hernia sticking out for it to be a hernia, and C, women can get hernias, then it's likely you're not going to be diagnosing these women. And so we started kind of coming up with some talks, and I remember I would give some talks about these, and there's a lot of people kind of, oh, I don't know, that's kind of your population, Shirin, you're in California or you're in Beverly Hills. And as you know, Bruce, you and I, most of our patients don't come from our vicinity. They travel to see it.
Right.
So that's not really like my patient population is not all like movie stars and Hollywood people. People like come from all over. So that wasn't, I didn't like that kind of poo-pooing of what I was saying initially. But now we've gotten to the point where people are listening more. And I always say that hernias, occult hernias, are like chest pain in that gender disparity. And you may know a lot of new studies that show that women don't present with heart attack pain the same way men do. So men come in, they have left-sided gripping chest pain that radiates to their left arm. Women may have it radiate to their ear or their right arm, or they may feel heartburn or anxiety, and it's not the same. And then the women therefore die of a heart attack, and the men gets taken straight to a cardiologist for a cardiac catheterization. So once someone figured out that women present differently, then now we can improve their outcomes from heart attacks in women. So I feel like hernias are similar, not as dramatic. We're not necessarily having more women die, though you can argue maybe more women are dying because femoral hernias are being missed, and that's the real hernia that has a once missed, and if you get to an emergency state, there's a 5% death rate. No other hernia has such a high death rate. But they're being hurt, H-U-R-T, right? They're being hurt. And we showed our study, which we presented recently at Pacific Coast Surgical Association, hopefully will be published, which is women get about extra over 1 year delay in diagnosis. They usually present with more pain. They have a significantly better outcome after the repair. And they're more likely to be prescribed narcotics before they see me, which is horrible, right? Because you're exposing women to opioids unnecessarily for a completely treatable hernia diagnosis. And many of them have other operations done. They have their tubes and ovaries taken out and gallbladder taken out, appendix taken out. They're told, on their head. So a lot of delay and unnecessary treatments done before hernia. So the more we understand that and talk about that, and the more the medical society accepts that and doesn't say, oh, that's just, Towfigh's unique patient population, then we're better at it. And I must say, the last several years, we have had specific female hernia topics discussed in all the societies that I've been to, including SAGES, which we had a hernia session. And this year at SAGES, they had a female patient, actually my patient, but they had a patient as part of the panel to express their frustration. Please listen to us with our pelvic pain. I self-fund a annual research award to anyone who includes gender in their hernia research project. Again, to help promote more research into this. And lastly, I would like to say that all that we've done so far surgically, whether it's the mesh we use or the surgical technique or the clinical trials, have been male-centric.
Mhm.
And I have a great slide. It shows, I think, 7 different clinical trials, thousands of patients, 17 females among those patients. Almost all of them had 0 females. One of them had 7, one of them had 10. So that's just not appropriate, right? And I would argue the mesh we're using is made for the male pelvis, and there are shapes and sizes that should be changed to better treat women's hernias. And then maybe therefore we won't have as many women with bad outcomes from hernias compared to men.
Yeah, I think it brings up that data science principle that when you aggregate data, it reflects the dominant average, in this case, males. And when you do that, you unintentionally you harm marginalized subpopulations and minorities, in this case, women. And we should learn from that. We should learn from the systems and data science principles where we should equally study and analyze. And when we do data science appropriately, we'll see patterns that are different, and then we can have optimal variety. Like you said, it would be a different shape and size of mesh for women pelvis, rather than trying to do one size fits all. Data science is really clear. It's agnostic. And when you do it right, decentralized in each local environment, then you can have each local environment reflect the unique variables and minorities, as long as you don't aggregate, and then it'll be dominated by, old white guys again.
I have a question for you, Bruce, because the way that I see it is, and you and I have had very similar practices, we tend not to see the typical simple 30, 40-year-old male with inguinal hernia, right?
Yeah.
We see the one who's had complications, and it could be like a reaction to the mesh. It could be adverse outcomes with something. Then we start seeing patterns. So we start seeing patterns in our little niche that the rest of the world has not yet come to appreciate. And you can talk about it, et cetera. But after many years, eventually the rest of the world comes to appreciate what we noticed a decade ago. How can that be better optimized?
Yeah, I think the honest answer is having and I'll give an analogy to the pandemic, because I think a lot of people are aware that the pandemic was very complex. If we had a data and analytics infrastructure appropriately deployed in every local environment, we would be able to see those patterns and generate those predictive algorithms very quickly. When the pandemic hit, one of the problems was it was a very complex virus. In some people, it was a horrible disease, and they ended up on a ventilator and died. Other people were asymptomatic, and some people had GI symptoms, and some people had respiratory symptoms. And so the same exact thing, like hernia or a virus, in different people could have very different symptoms. And if you don't have a data, no one doctor or even a group of doctors is going to be able to figure that out. It's too complex. But if you do collect the data and look for the data points, and you described several data points in women with hernia, pain during sex, other types of symptoms that were unique. If we had a data and analytics infrastructure appropriately in place for measuring patient outcomes and learning from them, we could identify those pretty quickly. But we don't. And because we don't, we can talk about it, and we can talk about our own experience with it. We made some progress, but nowhere near what we could if we had that data and analytics infrastructure in place. We're starting to get more, the research is getting a little more along these lines, but again, it's more traditional research than it needs to be every patient in local environment. And so they are starting to see diabetes is not just diabetes, obesity is not just obesity. There are subpopulations and clusters that are different. And that's getting a little bit in that direction, but utilizing traditional research mechanisms is so slow and so costly. We really need to be doing this in real world, everyday settings for every single patient. When we do that, then the ability to learn and improve will accelerate quite a bit.
It's like cholesterol. First, okay, high cholesterol is bad. Then like, well, you have good cholesterol, you have bad cholesterol. Now within the bad cholesterol, there's good bad cholesterol and bad cholesterol.
Nice.
It's just so complicated, but at least we're getting there.
Yeah, I think we are. I think the pandemic opened a lot of people's eyes that because we didn't have a data and analytics infrastructure in healthcare, we essentially did the same thing and had the same result as the bubonic plague hundreds of years ago. We had a shelter in place and PPEs, and it's really sad we're utilizing the same science today that we were 400 years ago. And there is a very robust science around systems and data that we need to be utilizing. It's been applied to climate. It's been applied to baseball. It's been applied to entertainment. It's probably time that we should apply it in healthcare.
So why do you think it's not a part of healthcare? Is it a money issue or an interest issue? They just need leaders like you to.
I think it's a mindset thing. We're so trained into reductionism and reductionist science that we think that's how healthcare has to work. And it's a little bit of a fear-driven thing because when you understand the degree of complexity and how messed up things are and how much tragic harm happens, like we're talking about just in hernia disease, we see it. It's kind of overwhelming. It took me about over a decade to learn it, but I think the timing's getting better and better. I think more and more people are recognizing the way we're doing healthcare, and the reductionist approach is not working. It's not a solution. So I think we're going to see this happen over the next several years. And to me, I'm very hopeful because if we didn't have this other science to use, it'd be kind of depressing, but there is hope. And that kind of leads me to, I know you've done some work in, what's considered artificial intelligence. I know you've done some research. I was wondering, because it really is, I think we're in its infancy, right? In healthcare, like you're just talking about, but maybe talk about your perspective on AI, artificial intelligence, and what you've seen so far in healthcare and what you see the potential is.
I mean, the potential is a lot. The research that I did is based on my experience. We have a questionnaire that everyone fills out. We call it the Hernia Health Questionnaire. And I've been using it since 2008. So we have thousands of patients that have had this questionnaire filled out. And it got to the point where my nurse usually takes that questionnaire in with the patient, and she comes out and reports to me, and she'll tell me if the patient has a hernia or not. She already knows based on the boxes that are checked, right? So one of my residents said, "Well, really, you feel like this is predictive? Your question?" I'm like, it totally is. If I just look at it, I know if they have a hernia or not. Because they'll come with groin pain, let's say. And he's like, "Well, we can see if we can come up with a score or some type of scoring system." So we have what's called hernia scores based on this, and we came up with an algorithm. We work with this PhD from Berkeley, UC Berkeley, who's like all into machine learning, and they came up with an algorithm. So you basically fill out the questionnaire, and it spits out a percentage risk that your groin pain will be cured by a hernia repair, as opposed to, let's say, a hip problem or ovarian cyst or other reasons to have groin pain. So we thought this would be really great. It was supposed to be launched back in December. Well, we're now in May, and we haven't launched it yet because we then start prospectively using it on random patients. And it turned out, yeah, globally it works, but in individual patients, it's a little bit inaccurate. And so we're adding more data to it to help strengthen that algorithm and make it more reliable, because you don't want to put anything out in the public that's not reliable. But it's really great because people with groin pain can have, it could be like LeBron James, where he's got an adductor tear. It could be he's a lady with ectopic pregnancy. It could be someone who messed up their hip. You could have appendicitis, or it could be a hernia. How do you tell who's who? Especially if it's not an obvious hernia, or maybe it is an obvious hernia, but that's not the reason for the pain. You undergo hernia surgery for no reason. So it's really helpful for doctors and also for patients who feel like they're not being heard. They at least have some tool. So I'm very excited about our hernia score. We're just not ready to go public with it yet because it's not a perfect system. I don't want to mislead patients by having like the wrong score. But yeah, it's machine learning, which is a type of artificial intelligence.
Yeah, you're describing the application that you can do in your local environment where you collect data, you identify data points that have an impact on what you're measuring. You apply that and then you learn from it and then you update it with more data. You're doing that feedback loop that you need to do to have algorithms get better. I think a lot of healthcare, we have, static algorithms and they're going to get worse. So, they don't perform very well to start with, especially if they're aggregated data. But what you described in your local environment to do, my understanding of the science is if we did that in many different local environments and then network those algorithms, that can give us the highest predictive ability. So that's what we're driving towards, because then you can reflect differences in different local environments, and you'd have yours reflects a lot of across the country, but the highest complexity patients, and where, some maybe a general surgeon
Right.
in Mississippi would reflect that population locally. And then when you network all those algorithms, you then can have a much higher predictive ability. So that's great.
It's kind of like when you get your credit score, there's like 3 different companies you can go through. They all give you different scores.
Yeah,
But it's different algorithm.
I'm going to talk about, we're going to do a session with a data scientist, and one of the papers I'm going to talk with her about is there's a paper that is out there. There was one data set and they had 29 expert data science teams do analysis, and they came up with 29 different results because it's not a perfect science. And the data, the analysis should be used to gain insights, not to prove something is 100% perfect. But when we talk about gender bias, your passion, like mine, around focusing on the patient and having the patient be a part of the process rather than just doing stuff to them. Maybe talk a little bit about your experience of patient-centered care. How important it is. Sometimes they come in very knowledgeable. Sometimes they come in and say, "Do whatever you want, doc." But I think it's extremely important to understand their fears, their goals. What subpopulations they fit in, what clusters they fit in. Maybe share your experience, because I know you're very passionate and very good about including the patient in the process.
Yeah, absolutely. My first job was at a county hospital, the largest county hospital in the US, and our system was not very patient-centric. The patient had to conform to whatever resources were available to them. The clinics were, they would show up, like 300 patients would show up, and then they would just wait until it was their turn. There was no like orderly set, and I was in charge of redesigning all of the outpatient clinics. We had something like 700 different outpatient clinics in the LA County system, and make it more patient-centric. So that was my initial kind of introduction to, patient flow and making sure the system is optimized for the patient's needs, not necessarily the doctor's needs. So that was great. And then I moved on to my next job, which is at a private hospital. It's a very well-known Cedars-Sinai. It was ranked number 1 in California, number 2 in the nation. Very patient-centric hospital. I learned from other colleagues of mine how to really make sure that you have good relations with referring doctors and call patients and so on. We knew doctors by their first names as opposed to like anesthesia or GI, like it's more personal care. And I found that now patients are flocking to me that needed more attention. They're more complicated. They need someone to listen. And then I felt even in the system where I was employed, I was limited as to like how much time I could spend with some of these people and how I can kind of move my career in the direction of these complex hernias, which is why I'm now my own boss, and I can spend an hour or even, and rarely, but sometimes up to 2 hours with a patient, going through everything that's been done to them, figuring it out. If they want to cry in my office, we have extra soft tissue paper that my office manager keeps specifically for that, because as you know, patients can cry when when they've been through a lot. And yes, I try and help them as much as I can. Sometimes it's a hernia issue, sometimes it's not. But I'm still there, almost like they call it concierge now, because doctors that our concierge really try and meet your needs regardless of what it is. As a surgeon, we're not called concierge, but the service that we provide can be optimized so that patients don't fall through the cracks and get appointments 8 months from now, which is not appropriate, and um, are just shuffled around. I'm not that surgeon that says, "Not my problem."
Mhm.
It can be not my problem, but let me find you the right doctor, and I will call that doctor for you. We've done the same, together. You call my office, I'll call your office, make sure that records are sent and orders are done. And can I give you a really brief story? One of the founders, actually, of the American Hernia Society, a very senior surgeon at my hospital, really look up to him. He really taught me how to really care for the patient individually and meet their needs at all levels, right? So it may not be in his specialty, but patients come to see him just because they know he's intelligent and will address their needs. Yesterday, we had a celebration party announcement. One of Ed's patients, who he's treated for 20 years, he's known these patients. Or how many surgeons do you know who know and treat their patients for 20 years? Not really a surgical thing to have a 20-year relationship, but that's Ed for you. Just donated $100 million to our Department of Surgery. We're now the Jim Eleanor Randall Department of Surgery. Very uncommon to have a Department of Surgery named.
Yeah.
Purely based on their very personal relationship with Ed Phillips, and that's something that you just don't see anymore. I strive for that, but it's just not seen anymore, where you have a relationship with your doctor for 20 years and enough to donate $100 million.
That's like a traditional primary care, but
We
things,
think
I think it's two things. Things have gotten money driven and so complex, but what you're describing and what you strive for, what I tried to in my practice was going away from the volume model and go to a value model.
Yeah.
That patient. And I think I'm seeing finally, like we were talking about earlier, the timing I think is getting better and better. People are realizing that the volume model is not sustainable, and not everybody yet, but if we can show how to do value, put financial data with outcomes data, and show tangibly with data science how we can measure and improve value-based outcomes, I think that's going to help kind of transition healthcare to a sustainable system. But that's great. Tell Ed I said hi when you see him.
I will.
Let me ask a couple of more personal questions as we're closing this session. And thank you so much for your time and all these great stories and experience. Do you have any movies or books that you've seen or read that's very inspirational? It touches on, improving our world, improving healthcare, anything that comes to mind that you'd like to share?
I'll tell you, my brain works like I like solving puzzles. And so any movie or book that kind of aims at like coming up with solutions to puzzles or talking about anything related to puzzles is what I gravitate towards. I also love stories. So I tend not to read books that are fiction. I tend to read biographies and autobiographies. I just finished Michelle Obama's book, which was great. And I'm starting her second book, which was given to me as a gift. I learn from people's stories. And the Sages podcast that I was hosting, we called it Sages Stories because I just learn people's stories. You learn so much about people little details you never knew about, their upbringing, what got them to do what they're currently doing, what makes them tick. That's my favorite, is anything that has like a personal story to it. And I think maybe that's why I spend a lot of time with my patients, because I'm like, what's your story? As opposed to like cutting them off at like, you have a hernia or you don't have a hernia, right?
That's so insightful. I think, just in what you described, I can understand why we've become close friends, because I'm the same way. I like nonfiction. I like learning about people, companies, how they, how Phil Knight built Nike from it. It took him over a decade before he could get a loan without feeling like a criminal, even though he's generating like $12 million a year in sales. Every time the boat with all the shoes came in, he had to go to a bank and try to get a loan. They wouldn't give it to him. And the stories that he had to go through, the trials and tribulations he had to go through to become successful. That's just one example. But I also, when I was a kid, I had an uncle who would bring over from, I forget what magazine, but he would bring logic problems. I loved doing.
Yeah.
I think, we have, for some reason, our brain is very, very similar.
I really appreciate what you're doing because there aren't that many people that would dedicate their time to, I think it's somewhat of a frustrating thing to do, which is something you're very passionate about. And I understand it, but it's very hard to communicate the importance of what you're doing to the layperson. Patients think very much into like black and white. Industry is looking at just, how they can make money, and long-term projects and things that can kind of turn the Titanic around, so to speak, are very difficult to latch onto. So thank you for what you're doing. And I'm just doing my thing, trying to keep telling the same story and hopefully more people listen about women and the need to improve. We need to improve our meshes that are out there so that they don't hurt people. We need to improve the care that women are given so that they're not delayed in their care and become opioid dependent for zero reason. And it's what makes us happy.
One of the things I think we haven't really answered is how do you really build that data infrastructure to truly do real world evidence? And I'd love to get your thoughts on what's needed there.
Yeah, that's a really good thing. I didn't follow up on that. Shirin, you talked about your own data and how valuable that is. And you talked about some of the output you're doing with a predictive tool. Maybe share with us a little bit about how you've developed your own data capabilities and how that came about and how you manage that. Because, I think ideally, like I mentioned, we should all have a data and analytics infrastructure, but most clinicians don't have those resources. So maybe share with us how you've done that.
I mean, I trained at UCLA. It's a very academic program. It's 2 years of mandatory research, and that really instilled in me a very academic way of approaching everything. So what things I like to do, I try and back up with evidence. And so from the very beginning, I started gathering my own data when I was in clinical practice. And you have residents that are looking for projects. I often have residents want to spend their 1 year of research that's mandated at our hospital with me because I do have a database, and therefore they can use that to come up with questions and help get those answered. Mentoring is a big thing of what I enjoy doing. And so we have pre-medical students that sign up full-time for 1, 2, sometimes 3 years. It's nice to have that kind of continuity. So I have young people basically that help maintain it, and it's a win-win, right? So they maintain the database. So therefore I learn from my patient population. They get research projects out of it, which helps them for their next career. And it works out really well. I don't know why others don't. In my division, I'm the only one that has a real database. And I mean, I don't know if they feel like they're too busy to do it, but it's really priorities, I think, because it doesn't cost that much.
Well, and I think the mindset you expressed multiple times since we started talking today is that you're doing it for improving. You're not doing it to try to, prove anything. And that's a mindset change I think we're going through in healthcare.
My last question is, how do we build that mindset in other physicians and medical professionals and caregivers to really start to build that brute force or that groundswell for data science and healthcare?
I always say it would be great if every surgeon had interest in research or interest in looking at their data. But I say, take those who want to do it and empower them to do it. Give them resources, time, money, whatever, to do it. And then the other surgeons that don't want to do it, maybe they're really good at just taking care of patients, right? Have them do that and don't demand that they also do research, for example, and just have them collaborate. So the researching surgeon, for example, will I'll take care of your database, right? I'll do the database. You just keep operating and don't expect the clinical surgeon to also do research, or the really good outcomes research surgeon to also maintain a very heavy clinical burden, and instead bring them together as like a yin and yang, So each one helps the other come up with a division now that's very strong and has people that help each other learn. That's how I would run a division, for example. I don't see that done. Everyone has the same kind of, you have to do this many surgeries, you have to research, you have to teach. Like everyone has to do that. And some people don't have strengths in one of those.
It's like we were talking about, where patients are in clusters, because we're human beings, doctors are in clusters too. And
Right.
you should have people do what they're good at and what they enjoy doing.
And empower them in doing that, right? Give them the resources to excel in what they're really good at, then they'll be happy and productive.
Well, that was great. Anything else? Shirin, I can't thank you enough. And I hope we can get together a little longer time in person.
Yeah.
Meeting. I'm definitely going to be at the hernia meeting in Chicago. Spend some time together there.
Thanks so much.
Thanks for joining us for another episode of Data Nerds in the OR, a surgeon's journey toward value-based care. You'll find links in the show notes to any resources mentioned in today's show. If you're enjoying our podcast, please subscribe so you never miss an episode. And if you want more content like this, you can always sign up for our Smart Surgery blog via the link in the show notes. Or if you want to ask Dr. Remshaw or the team a question directly, please send an email to podcast@caresyntax.com. This episode is brought to you by CareSyntax, the leading vendor-neutral surgical intelligence platform. The CareSyntax platform can ingest and analyze data throughout the surgical workflow, including clinical, operational, financial, and outcomes data to capture a complete picture of the surgical pathway. That data can produce actionable insights to enhance efficiency and innovation for surgical teams, hospital administrators, and medtech developers, driving innovation for the future of healthcare delivery. CareSyntax impacts over 3,000 ORs and more than 3 million annual procedures across the globe. Learn more at www.caresyntax.com.